Hello, it is such an honor to be part of this course. I would like to thank everybody. I learned so much from listening to the other faculty. It's really an honor to be here. So the latest and greatest thing now in scoliosis is Schroth therapy. Even though it's been around for 100 years, it's now hit the United States. And what we found is when people stand up and get an x-ray in a Schroth position, their scoliosis could look vastly different. In fact, it could look so different that about a third of the time, the Cobb angle would recommend a different form of treatment. So I'm not sure what to do with this information, but make sure when your patients are getting x-rays, you ask them if they're standing in a normal or a Schroth position. Now, here's my favorite study from last year. We gave parents psychological tests, and it turned out that if the parents were one standard deviation high in anxiety, the children were 2.5 times more likely to be using narcotics the next week. So now we offer classes to the parents ahead of time with nurses that seem to calm their anxiety. So all around the country, people are figuring out that having a dedicated spine team in the operating room leads to better outcomes. We found that it leads to shorter surgeries, less blood loss. And once you do this study, you then have leverage to administration to have more and more of a dedicated spine team instead of having the ENT nurse in your room. And the idea of team has been brought up by other speakers. And I would propose to you that some of the best efficiency we can have to help our patients is to make the team feel part of the surgery. Every weekend, I send out an email. Right now, it's to 38 people planning each individual surgery. And almost every week, somebody gives me feedback to improve what we're doing. So let's talk about scoliosis in specific. Once the curves get to 45 or 50 degrees, 3 things happen. It deforms more over time, the patients have pain, and there's pulmonary dysfunction. They don't all have pain, but the chances of pain start to increase. So the indications for surgery, 45 to 50 degrees. So let's go over a typical case. 59-degree curve, it bends out only to 53, so it's really stiff. And notice on the lateral that there's not very much kyphosis. This is the typical curve. This is what the child looks like. There's an asymmetry. The rib hump is because the spine is twisted. And a frequent controversy is, where do you end at the lower level? And what I would recommend is, if there's a double curve, you want to get the vertebrae that is most closely bisected by the center sacral line. If there's a single curve, you want the lowest substantially touched vertebrae, which means the pedicle touches the center sacral line. Now, people often forget to look at the sagittal when choosing an LIV. In a multi-center study, we proved that if you use one of the, I just switched, unfortunately. In a multi-center study, we showed that if you choose a lower instrumented vertebrae that is behind the posterior sacral vertebral line, your chances of DJK are 17%. So you might want to discipline yourself to always look at the lateral x-ray first when choosing the LIV. Blood pressure is a big issue. We now have a screen right in our operating room, so everyone in the room can see it. We want the mean arterial pressure in the 50s or 60s while we're dissecting to save blood. But once the rod is cut, boom, it makes a loud noise. That's when anesthesia knows that they should raise the blood pressure at least to the 70s, because when you have higher blood pressure, you perfuse the cord, you're less likely to lose signals. In a prospective multi-center study, we found that when you lose neuromonitoring signals, 20% of the time, all you have to do is raise the blood pressure and it comes back. Now, other speakers have brought up, overuse injuries. And here's one of my favorite studies. At the SRS, spine surgeons have high rates of overuse injuries. In fact, cervical radiculopathy, which I have, I'm on a dose pack right now, spine surgeons are 100 times more likely to have cervical myelopathy than the general population. So if you look on the right, this is an EMG study of a spine surgeon putting in screws. And if it's done manually, you can see it is routinely above 20% of the EMG maximum. That's dangerous. Once you go above 20%, and it happens not only in neck extensors, but your traps, your biceps, your forearm, then as a piecemeal laborer, carpenter, you are at a higher risk for an overuse injury. And you see in this graph for power is below the danger zone. So as surgeons move more and more to power, we're protecting our bodies. So we have done a multi-center prospective study of 6 early adopting surgeons using power, not only to put in the screw, but to prepare the pedicle with a relatively flexible drill bit. And over 22,000 screws, we found out that 99.98% of the screws did not cause a complication, did not need to be revised. Now, these are done without robots and without O-arms. So if this type of good results could be reported in multiple surgeons' hands using freehand technique, that may be why I'm a little bit hesitant to be moving towards a robot or an O-arm at this time, but clearly in the future that should be better. And here's the tools that we use: a flexible drill bit, because if it's flexible, it's almost like a ball tip probe, and it finds the soft cancellous bone and kind of bumps off of the hard cortical bone. Then a reamer, then put in the screw. More and more surgeons are using this device, which is an ultrasonic scalpel. It could be used for facetectomies as well as for osteotomies. There's less force in the patient, less force in the surgeon, and less blood loss in a study. Okay, now let's talk about derotation. Derotation is a very difficult subject to teach in a slide. I highly recommend that you do a cadaver course, or please come and visit me or somebody else watch it. It's really not that hard. It's just hard to teach in slides. So there's 2 forces in derotation. One is you bend extra kyphosis into the concave rod. And then you imagine that the concave rod will be pulling upwards on the lower screw at the apex. So here you see the concave rod has lots of extra kyphosis. We're slowly pulling the spine up to the rod, and note at the same time that the rod flattens a bit. So even though the rods are differentially bent in the beginning, they end up about the same. And now here's a picture of the second rod, the convex rod. This rod is pushing downwards on the side that's high and aids in derotation. Now here's where it gets really complicated. So you don't just have differential rod bends, you also have derotators. This is an example of derotating the apex of the thoracic curve versus the lumbar curve. Now with these 2 techniques, these very, very powerful tools, we are starting to see more and more that we can almost 100% derotate a spine. So when the surgery is done, if all the pedicle screws are pointing straight forwards, that's a sign that the spine has been derotated. And at the same time, of course, we want to pull the spine posteriorly to create physiological kyphosis. This aids in opening up the chest, has good pulmonary aspects, and as well, it aids in having a more normal contour of the cervical spine, because in AIS, there's frequently kyphosis in the cervical spine because there's not kyphosis in the thoracic spine. Now, we expect the girls to look better in the coronal plane, and it's mostly women. The rotation is really an amazing correction, and I've seen girls in the recovery room crying, holding their chest, saying, I no longer have that bump there. Because while we see the bump in the back, the girls see the bump in the front. And we're now able to basically 100% correct that if the curves are flexible enough. The latest fad in technique is tethering. My disclosure is I've designed a tether, I make royalties on it. This is an example from a busy tether surgeon's website, a mature patient, 39-degree curve, got a tether, left shoulder ended up high. I don't know, is this good? Does this child need surgery? Here's a paper by Peter Newton, who's very honest. This is the longest follow-up in tether. And he shows that tethers, compared to a posterior fusion for a selective thoracic fusion, had a higher revision rate, less scoliosis correction, no thoracic rotation correction, and the implants failed more than half the time. Now, it's not always bad if it fails after the spine's straight, but you can see here clearly that despite the excitement around tethers, it should be considered experimental still. Okay, big curves. There's two things we want to think of when we approach really big curves is time and distance. This is an example of using a temporary distraction rod. The hooks at the top are on the ribs. You want the rod off to the side so you can work on the spine, put in screws as you're stretching and stretching and stretching. And here's a video showing how you literally just keep stretching the spine. It is absolutely mandatory that the maps are around 75 or 80 now because you are stressing the spine once you start to stress it. And we would expect what happens is as you stretch the spine derotates so it becomes easier to put the pedicle screws in these 100-degree curves. And this is kind of what we expect clinically, all posterior. We should be able to create physiological kyphosis. We should be able to make the patient look better, get rid of the hump without cutting the ribs. And as we conclude, I want to make it clear that I think that there was a big wave towards VCRs. We went to meetings and you felt if you weren't doing a VCR every day, you weren't really macho. I'd propose that you almost never need a VCR for idiopathic scoliosis. If you can get 10 or 15 degrees correction with each pontiostiotomy and you do a bunch of pontiostiotomies, you can get lots of correction. For example, here, there were 2 posterior hemivertebrae. This patient has a very high DAR, and this DAR, if you do a VCR, is predicted to have a 95% chance of losing signals. That would give me more gray hair. Another way to approach that is just do 4 pontiostiotomies, do more correction over a little bit longer distance, and this is exceedingly safe and has a much lower chance of losing signals. And in the concluding slide, which is not reporting great results, we did a multi-center study over 6 of the busiest pediatric centers in the country, and we found out that when spondylolisthesis is corrected only from the back, plus or minus a TLIF, I'll still call that from the back, there was a 46% reoperation rate. Now, this is a time where young, active adolescent athletes behave a lot different than old people that sit at a job. So now what most centers are doing is if we have an active athlete that wants to return to sports, when we do a spondylolisthesis surgery, we do an ALIF. So far, I have not seen an ALIF fail. That seems a very high rate of fusion, and we let the kids go back to full sports. Now, this might look a little bit out of the box on the right side, but you see when L5 is totally in front of S1, and I even do this sometimes for 50 or 60% slips, you can do it all from the back, and you can put the S1 screw right across the disc into the L5 body. So from a posterior-only approach there, you've supported the anterior column, and you've avoided the risk of pulling L5 back, and as long as you correct the kyphosis, then the sagittal plane is good and these patients do well. I've even had a kid play scholarship D1 basketball an entire career after this surgery with no more pain. So I'd like to thank everyone for putting this together. It's such a fantastic course, and I welcome some tough questions, please.
Thank you so much. Dr. Skaggs, when we switch screens, this is a treat.
I learned a lot every time I hear Dave Skaggs talk.
This is absolutely amazing. Just in 20 minutes, a widespread mix of everything.
I got to go back to the beginning of your talk and listen to it again. Then I can ask a cogent question. That's my problem.
Dr. Chapman, you're live now. I'm sorry, your mic was off. You're live now.
Dr. Skaggs, thank you so much on behalf of everybody. I know you're not feeling great, and it was so cool to have you with us. And again, the atmosphere in the room, we have, I think, 8 fellows here and a couple of other visitors and team members. They're all going like, wow, this was unbelievable. 20 minutes of highlights. I know you've accused me in the past of being too nice in my compliments, but no compliment is good enough for opening our eyes towards this. Now, all praise aside, I think, number one of the key insights for me is that we always have kind of thought about this dichotomy of neurosurgery and orthopedic spine surgery, but we've completely forgotten to close the loop to our pediatric colleagues, who are usually orthopedic surgeons. But all of your work and that of your predecessors has taught us so much in terms of how to do proper spine surgery. All the instrumentation is based upon pediatric insights. So kudos to you guys. Let me start my first question with the first slide that you showed on the fact side, and that is the Schroth method. So when you see a young, healthy, let's say 11, 12-year-old girl that is perimenarchal, she has an early Rissa stage, and she has a curve somewhere between 15 and, let's say, 32 degrees, measurement error plus minus, a healthy, competitive athlete. What would you do with this young girl in terms of your practice, a highly competitive LA practice? What does she get?
So you're assuming this is someone who needs surgery?
No, this patient was sent to you by concerned parents, and you've gotten their anxiety test, and they're great parents, and this girl is a healthy, strapping, growing young girl. She is maybe just started her menarche. She is, again, 11 or 12 years old, totally normal development, plays on school teams, has no real pains, no major concerns from her end, but her parents are concerned because her curve has increased from, let's say, 12 degrees to the 30-degree realm.
Got it. Okay. So we have a 30-degree curve in a growing child. So number one, I love how you phrased the question. The kid's healthy. Scoliosis is not a bad disease at 30 degrees. She could have a 30-degree curve her whole life and participate in everything. So that's number one. Number two, the only thing we could offer with scientific evidence that's good is bracing. So I always offer a brace, and the best studies out there show that the brace is only really effective with daytime use, a typical TLSO, and it's most effective if you use it up to about 13 and a half hours a day. After that, it doesn't help anymore. So it's dose dependent. We tell the patient, wear it as much as you can during the day, but of course you have to take it off and play sports and have sleepovers and go to the beach. We don't want it to take over their life. Now, if the curve does get to the point we need surgery, particularly if it's a selective thoracic fusion or even down to L3, they can basically all return to sports really at any level that they want to. I am a little bit against football, parachuting, and powerlifting, but aside from that, I tell people to go for it, and I'd say the average kid gets back to full sports between maybe 3 months.
Outstanding. Thank you for that little outline. My second question goes into the surgical skills set. So this is directly pertaining and prefaces, for instance, Dr. Johnson's next big picture thing, or Dr. Chua's excellent lecture on robotics. What I'm seeing in you is a culmination of so much wisdom, but also surgical tactile skill. And you've addressed this earlier, that robots are not there yet, but how long did it take you in your career to develop this skill, this touch part of putting instrumentation right or distracting a certain amount to try to have the right thing? How many years in your practice? You're a seasoned veteran now.
Yeah, so I have to say that I put in my 10,000 hours as a carpenter. So literally you just put in screws all day, and if you put in screws and hit a live wire, you quickly learned about it. So I think that coming into it with that background was helpful. What we do now with residents is the first time the resident's with me is in my office with the model, and they're practicing the drill technique. And then the first day of a really new PGY2 resident, they are putting in pedicle screws opposite me. So it's interesting that 99.98% of 22,000 screws that didn't cause any harm, those are also including the resident screws. I like what you said about tactile. Yeah, if you have this flexible drill bit and you're going slowly, you can really feel when it's soft cancellous bone in the middle of the pedicle or the hard cortical bone in the medial pedicle. And I think that we have to teach our residents that tactile feeling is so important, and they have to be able to trust their hands, because every once in a while, the imaging might be wrong. And if it's wrong by a few millimeters, that could hurt something.
Great answer, thank you. And so the learning curve is something that can be maybe shortened by training, and it's not just all virtual. As much as it's become a catchword, there is an actual practice component, whether it's wood screws or actually cadaver models or plastic models. And obviously, hopefully next year we can have your presence here again to teach our wonderful fellows and course participants directly how to kind of look at the finer points. Let me ask you another question, neuromonitoring. So this is something that in our healthcare system, which is 52 hospitals or so, is being heavily discussed right now. From seeing your highly kind of sensible physiologic feedback, using neuromonitoring as a live feedback module, is there even a remote question that deformity surgery should be accompanied by IONM, intraoperative neuromonitoring?
Yeah, I know that this is a potential legal question, and we're being recorded, and people tend to, say gray answers, but this is not a gray answer. If you're doing spinal deformity surgery, I believe you should have outstanding neuromonitoring, including motor evoked potentials. I've probably lost signals about 200 times, and because of good neuromonitoring, we were able to bring back signals, and I've thus far never had any scoliosis case paralyzed. So I think the neuromonitoring is probably the most important person in the room, and when they speak, we should all shut up and listen. The other key thing with neuromonitoring, and this is kind of one of the standard things that people should do in crises, is the surgeon should repeat back. So if the neuromonitoring person says, we've lost MEPs in the left leg, the surgeon should repeat back, we've lost neuromonitoring in the left leg. I've seen a few legal cases, and it came down to the neuromonitoring said, I told the surgeon we lost it, and he ignored me.
I appreciate the clarity of your questions, and I realize I monopolized the Q&A time, which is so important with you. Let me invite Dr. Johnson and Dr. Chuo, who are right here, to ask some questions before we move on.
Great. Dave, just incredible insight and career of experience. And I'm actually very interested in our offline talk about how we have to reconnect in Los Angeles, but it's how to teach young surgeons the tactile feedback, because as a neurosurgeon, we don't get that training through our residency, but there's other ways to do it. And also it's kind of what people bring to the table of what's their skill set and experience prior to them even going to medical school. I mean, did they chop wood? Did they do something that is tactile? Did they turn a screw? Did they sew things? Okay, for not to be sexist, but women sew things. And I'm always asking, and I want to know how to make surgeons understand tissue planes and tissue density. And those things are so vitally important, when you're working in the epidural space, and, so there are so many things. And that's something I think we can really improve upon with our trainees. And I like to hear what you're doing in your office, and you're having them use a power drill and things like that. So those are things I think that as we have less experience because of robotics and we're not doing open surgery anymore, we need to come up with other ways to be able to train these young surgeons to be able to operate on us when we're, older than
Yeah, I just hope that you're around to operate on me when I need it. Yeah, you're right. And I think that part of it is training and part of it is selection. We have this bizarre selection process for surgeons, where people that fill in the right test questions are the ones who are selected. And only when they get in the operating room, we realize that some people, I think it's almost genetic, don't have the three-dimensional picture in their head when you ask them to put a screw in a certain place. I think part of it is trainable. I think a really, really important part where I learned a lot is going to cadaver courses. And to this day, when I go to cadaver courses, I'd love to be with the other faculty and try out different things. For example, people are always worried about, am I going to go too far through the anterior disc? When you're on a cadaver, you realize you got to push really, really hard, and that anterior disc is actually pretty strong, and you probably won't go through it. I think the key to your answer, or my answer to your question, is repetition. So I think that the residents should just keep practicing. I have an endless supply of models and screws in my office, and I encourage them, please just sit down for 20 minutes and practice over and over and over and over. And then we lay down the neuro pathways so it becomes a habit.
It's called reps. In athletics, it's called reps. You do it over and over, and you throw the baseball, and you throw the bowling ball, or whatever thing you're doing, or a pool ball or something like that. Those are so important. Just it's hand-eye coordination, and it's tactile skills. I love it. It's a great topic.
And what's interesting in our society, if you do something really important, they start to train you when you're young, like golf or tennis. But it doesn't happen for things not so important, like being a surgeon. My daughter is now in medical school, and from age 5, she was reading x-rays with me, suturing with me in my house, setting fractures. It was interesting watching how much she now has that, genetically, as she comes to orthopedic rotations in medical school. Not genetically,
that's called congenital.
So let me ask you one more question whilst we have you online here. So that is volume. So we've talked about the value of repetition. And since you're a wonderful speaker in so many ways, but also are not afraid of stating something very clear, in the United Kingdom, they do have a unparalleled big data gathering process, and the actual national spine database, which if you haven't seen the annual report, I'm happy to send to all of the faculty. A gentleman named Mike Hutton puts that together. They've identified a critical lower number necessary for safe deformity surgeries. I think their best estimate is 40 surgeries in a year for a center. You've brought up so many things like teamwork, like a calm collective spirit and assessing patients and doing the surgery safely in a collaborative fashion. What are your thoughts in the U.S. on this? And is this something that is starting to get traction with regulatory bodies in terms of having a certain minimum number of deformity cases to do them safely?
I think you're absolutely right. In every specialty that I'm aware of, cardiac, neuro, if centers do a lot of one thing, they do it better. In Los Angeles, for scoliosis surgery, we do 5 times more than anyone else in town, and the most in the West Coast. So you just see things over and over. The problem is it could be perceived as restraint of trade, and I could see it become legal issues if certain hospitals or doctors don't want to give up that business. And I agree with you. Dr. Tolo and I discussed this, and we think that you shouldn't really do spinal deformity surgery if you're not doing at least 2 a month. That even seems a little bit low now because the technology seems to get more and more and more intense, and I can't imagine just walking into that operation if you don't do a lot of it. I think what's going to change things, and I actually watched this at a local hospital in Los Angeles, is once they have a bad outcome, which is unfortunately a child having a neurological injury, they look at it and say, this surgeon doesn't do too many of these. We don't want the surgeon to do these cases at our hospital anymore, because the hospital will start to realize that the legal risk is probably greater than the financial benefit.
Great answer. I'm going to ask a different slant of the same question to Dr. Theodore and Dr. Chua, who are both at the forefront of less invasive and minimally invasive surgeries and using technology. As a open spine surgeon who hopefully has an open mind towards evolving techniques. I always watch them and play with them in the lab to familiarize myself with them. What I see is a lot of OIFs, open internal fixations, and I contrapoint that to ORIF, open reduction internal fixation. So I see a lot of hardware placed with the spine in a catawampus position. Catawampus is Southern English for not straight, not properly aligned. And I see a lot of piecemeal surgery where basically a one-level surgery is done here, a two-level surgery is done here. In our last interesting case discussion session from last Tuesday, UCSF showed a horror case of a 38-year-old woman with 8 spine surgeries in a 3-year period who was fused up to L2, and she was completely off in all directions. So please, I don't know who wants to go first, Nick or Richard. First topic is actual deformity reductions of the short segment fusions that are so popular with a less invasive crowd. Is this something that you see? How do you avoid it? And secondly is, how do we treat the big picture and how do we avoid this kind of a piecemeal approach like a dentist of, I'll do this cavity today and the other cavity 2 months from now? So thank you.
So, yeah, that's a great question. Obviously, we're now thinking to the point where deformity starts with your first operation, right? Obviously, and now everybody's in tune to looking at global spinal balance and trying to figure out if fixing that 4-5 spondy is really the right thing or whether this person really needs a more extensive operation based on all the parameters and expectations for that patient. Nothing supplants good carpentry, nothing supplants getting good alignment, et cetera. So if it's a single level case and somebody's aligned, fairly well, you can reduce that spine and keep them in alignment, that's great. But to your point, if they're off balance to begin with, then the reality is we have to, you have to think about that. And I think what we see is people, and unfortunately, I think it's a lapse of judgment or maybe not good training where somebody will take a look at a case and say, let's just do this, and that's not solving the problem. So you really still have to understand all those principles have to be put into play, and that's why I said that utilizing advanced technology, image guidance robotics, is an enabler, and it can make one part of the operation potentially safer, potentially quicker for some people, not you, but for others. But the reality is that it doesn't take away from the fact that we have to look at everything in a global sense. So you're right. And when you see those cases are heartbreaking because, if you trace the steps back, the first operation was wrong, and then one begets the other.
Richard, any tips or tricks or how to avoid this kind of just piecemeal fashion of adding little bits? When do you pull the ripcord and say, this patient needs a global solution? This, as tempting as this outpatient surgery stuff may not be enough for this patient.
Well, I think the key for me is it's an evolving science. So even in the last 5 years, our understanding of deformity surgery, the parameters, what we can achieve, what we can't achieve, the implant technologies are changing that. So it's a moving goalpost, unfortunately. But to that extent, I think, especially for the attendees and the younger surgeons, I think it's really important to engage your patient. So be honest about your abilities and what you think you can achieve. Be honest with the patient about what the potentials are for doing a little surgery now that might require a big surgery later, but also be honest with the patient about pulling the ripcord and doing the big operation now, which still in hands like at SNI and other big centers, still has 30-40% complication rates, which are not insignificant. And to echo Dr. Theodore's point, doesn't matter what the enabling technology is, doesn't matter what the implant is, you got to be a good surgeon. You've got to know how to do a really good decompression. And since we're talking a lot about instrumented fusions, you've got to know how to do the arthrodesis. We all know this, but I think it helps us to remind us for every case, if we don't do a good arthrodesis operation, it doesn't matter what screw you put in and how good the curve looks at the end of the case, because if it doesn't fuse, it's going to be a horrible failure and revision. So be honest with yourself and your patients about your abilities and your techniques. engage the patient in the decision making. If we do a little operation, it might mean another operation later, or vice versa. If we do a big operation now, it might mean a higher risk of complications, revisions, et cetera. And with that, I think everyone will have a successful career and know that we're all still evolving. You know, I love the question, how many cases does it take to be proficient? The reality is, I hope I'm getting better every year, even though I'm on the tail end of my career. I hope I haven't peaked yet, and I hope I peak at the end when I can sail off into the sunset.
My final question for the great Dr. Skaggs is the following. Predicting the future is so hard. When I was raised in Texas Scottish Rite Hospital with the great Jean Dubuisset there, the thinking was that if we can preserve 3 motion segments below an adolescent idiopathic scoliosis fusion, the patients have a pretty good chance of kind of going on with a near normal life. You showed in your selection slide that this is kind of a little bit more soft now, it's less dogmatic. What are your impressions of long-term outlooks of survivability of caudal discs in terms of, should we just try to have as many mobile as possible as long as that vertebra, that LIV is somewhere in that fall line or not?
Great question. I think the studies are a little controversial, but it looks pretty clear that if you're ending at L4 or L5, there is an increased risk of long-term back pain. So we want to do everything possible not to do that. It looks like if you're ending in the high lumbar spine or even L3, long-term it should do well. The problem is we don't have great long-term studies, but from what I can tell, if you can end at L3, the kids will do well short-term. They can return to sports. They have enough motion to do everything they want. The long-term studies look like they should be okay for long-term back pain. And I would say that probably 95% of our fusions are able to end at L3 or above, maybe even higher than that. But it is an uncertainty. I mean, I just can't believe we put that big of a piece of metal and make the spine stiff and there's no other long-term problems. But the studies don't seem to suggest that there are. And one thing is I would like to thank all the adult surgeons. When I see what you guys are doing minimally invasively, I feel like I'm Attila the Hun, and I'm going to try to be more like you as I get better and advance. It's just kind of hard to get all that derotation through MIS, but I hope I keep learning from you. Thank you.
Great closing words. So I'll ask our course chairman, Dr. Oskuyan, what are we doing next?
We're going to go to the lab with Dr. Hart, who's going to show some osteotomy techniques.
Thank you again, Dr. Skaggs.